first couple of times. I need you to just roll with it. So,
You got it.
welcome. Thank you. Welcome, everyone. It is July, and along with that, we have a new co-host of the JVS Online Journal Club. So I'm Misty Humphreys. I'm a vascular surgeon at UC Davis. We do this monthly. And now Joe Hirani is going to be taking over for Paul DiMuzio, and he will be co-hosting with me. So tonight we have Johns Hopkins University as well as the University of Utah. And this month, the session is sponsored by the Young Surgeons Society. We have two really great papers that we're going to be reviewing, including the early outcomes of endovascular repair of the aortic arch using thoracic branched endoprostheses, and morbidity and mortality of common femoral endarterectomy. From Johns Hopkins, we have Caitlin Hicks, who is an associate professor. She is also the director of surgical outcomes research and an associate fellowship director. And the second-year fellow, Dr. Robbie Aura, who's going to be presenting. And then from the University of Utah, Dr. Callie Johnson, who is an assistant professor and co-director of the aortic program, as well as Dr. Thomas Serena, who is their first-year fellow. Only for another couple of weeks, though, then he'll be the second-year fellow. Our author guests, Dr. Sarah Zettervall is the senior author, and Haley Peng, who is a third-year medical student, will be joining us. Dr. Zettervall may be a little late as she is in the operating room, but she is hoping to be able to catch up with us. And then, of course, Dr. Rem Alkhouri and Dr. Michael Cheney, who are, Michael is a PGY3 general surgery resident at Western Michigan University, and Rem is now at the University of Chicago North Shore. And so we're excited to have both of them here as well. We have two special guests tonight. We'll be moderating Dr. Nathan Liang, who is an associate professor of surgery and bioengineering and also director of the complex endovascular aortic interventions at the University of Pittsburgh, and Dr. Kevin Sutherland, who is an assistant professor at the Division of Vascular and Endovascular Surgery at Duke University. We ask that you please stay muted. We will have you put your questions and comments in the chat, and Dr. Liang or Dr. Sutherland will may call on you to ask those if it's a little complicated. Of course, the event is being recorded for on-demand access. And then in August, our event will be on April 14th at 6 p.m. Central Time, hosted by NYU and the University of Michigan. And then all of the dates for 2024 are posted at vascular.org. So before we get started with the papers, I'm going to have Libby Weaver kick us off.
Thank you. So as Dr. Humphreys mentioned, this is the second iteration of the YSS-sponsored journal club session. And the goal of this is to highlight early career surgeon scientists, that is, vascular surgeons in their first 10 years of practice. So both of the manuscripts we're presenting tonight have senior authors that are in their first 10 years of practice. And all the faculty, presenters, and discussants involved are also early career vascular surgeons. So thank you for this opportunity to highlight our amazing superstar early career vascular surgeons.
Dr. Hicks, do you want to get us started?
Great, yes. Thanks so much for the opportunity to be here and to discuss this exciting paper about using TBE in the aortic arch. So I'm going to kick us off with just talking a little bit about TBE, or thoracic branch endoprosthesis. I do have a relevant disclosure in that I have a relationship with Gore, but it's not directly related to this. So the TBE, which is produced and commercially available through Gore, was approved by the FDA for use in the commercial setting in May of 2022. There's a variety of inclusion and exclusion criteria and indications for use that I don't want to belabor here because that's not the point of today's discussion. But I would like to point out that this was approved for use for patients that were at high risk for debranching of the subclavian artery. And that includes patient conditions such as morbid obesity, potential for duct or nerve injury, and carotid stenosis. And sort of for that middle indication that it includes essentially everybody. From a procedural overview, it's very much like a T-bar that all of us are familiar with, the exception being that you get arm access in some fashion. We do a fair number of TBEs at Johns Hopkins, and we typically use radial access, and it'll be interesting to sort of have some discussion about that, about how different practice patterns differ across different institutions. But essentially, you have a radial or a brachial access, and you have femoral access, and then you insert the device over these two wires. You deploy the device. It's commercially available for use in zone 2 currently. So you deploy it covering left subclavian, such that the portal is going to provide revascularization of the left subclavian artery. And then you advance and deploy your side branch component. And so you get a nice seal zone between the carotid and the subclavian artery, and you preserve flow to the left subclavian artery through that arm access. The majority of the data that we have available on this device comes from industry. Gore's original trial, their clinical study on the use of TBE for aortic arch and descending thoracic aorta in zone 2 was published a couple of years ago. The primary endpoints of this study were device technical success, and then the absence of a variety of different endpoints, including aortic rupture, lesion-related mortality, disabling stroke, spinal cord ischemia, renal failure, and unanticipated other issues. When you look at the results coming out of that group, and of course, this is the very sort of tightly controlled, industry-sponsored single-arm trial, device technical success was achieved in about 92% of patients. And really, those that failed predominantly because of access issues. And this device does use a large sheath. It's typically a 24 or 26 French sheath, depending on the size of the device that you're using. Primary endpoints such as aortic rupture, lesion-related mortality did not happen in any of the patients treated for aneurysm. Stroke happened at about 3.6%, and that was associated with a large learning curve about not snaring that arm access in the aortic arch or the proximal descending thoracic aorta. And then spinal cord injury frequencies were relatively low. If you look at outcomes in this device using the dissection patients, they were really very similar to that. And they also published data in the trauma and other lesion cohorts as well, which were much smaller ends. These were in the 130 range, and the trauma had about 10 patients. But all of the outcomes looked very, very promising. But you'll note that they reported them really only out to 12 months. So I think what we're left with is sort of this very exciting, promising device that moves us into a new space of an endovascular solution for zone 2 aortic repairs. But we are sort of left with this, what about the real world experience question? One paper that I know I'm familiar with that sort of tried to get to this early on came from Dennis Gable and his group out of Baylor, Scott, and White, and looked at TBE compared to surgical left subclavian revascularization with TVAR. This is 24 patients with TBE, and you can see that their technical success was excellent, and their operative mortality was extremely low. And ultimately, complications happened very, very infrequently with both procedures. But when you look at TBE compared to our standard left subclavian revascularization with, say, a carotid subclavian bypass or subclavian transposition, operative times were much lower in the TBE group. You only needed one hospitalization for most patients. And ultimately, the total length of stay in that TBE group was a lot lower. So potentially offering sort of a great solution to our patients that is minimizing the burden on the healthcare system. Personally, I think the TBE is really a game changer for zone 2 TVAR. We use it all the time. It's a really nice device. You just need the proper material, but all the other techniques are things that we're already familiar with. It's got a quick learning curve. It's easy to plan and execute. And as I mentioned, the industry reported outcomes are really excellent. But where we're left sort of wondering is what the long-term outcomes are. What happens to these patients long-term? How does that left subclavian branch behave? Because it is perfused through a retrograde flow mechanism. And then what are outcomes of proximal landing zone applications? And certainly there's a plan to do a zone 0 commercial application, but that's not currently available. And I think that's what this study that we're talking about today really gets to. So I'm going to stop there and pass it off to Robbie to talk specifically about the study.
Can you guys see my screen?
We can,
Okay,
if you want to put
perfect.
it into presentation.
Yeah, thanks. All right, that should be there. Hey everyone, I'm Robbie. I'm the second year fellow at Hopkins. Today I'm going to discuss a exciting paper titled Early Outcomes of Endovascular Repairs of the Aortic Arch Using Thoracic Branch Endoprosthesis by Peng et al. So endovascular repair of the aortic arch in the United States at this point is limited to these three main modalities, which are fenestrated branched, as well as parallel graft experience and hybrid repair, which is the latter has probably been the most familiar experience with most vascular surgeons in the United States. And within this fenestrated branch is where there's been a lot of development in the last 10 to 15 years. And this has been from physician modified to in situ laser fenestration. And then within this third subcategory is where the TBE comes in. And this is the only FDA approved off the shelf solution for zone 2 pathology. So very briefly, Dr. Hicks had already touched on this, but this was a multi-institutional paper that was published in the JVS in 2022, and this was looking at outcomes for zone 2. And as you can see, the outcomes of these pivotal trials, there was high procedural success up to 98%, and overall low stroke risks that range from 1 to 3.5%. And there was a procedure-related mortality of 0 and an all-cause mortality of 1.5%. So the current study looked to describe the outcomes of TBE for patients treated for zone 0 to zone 2 at a single center. They compared outcomes by zone of treatment, which had yet to be defined. So this population, as I discussed, was TBE for zone 0 and zone 2 to zone 2, and their exclusion was only the patients that had undergone TBE during their trial at University of Washington. Their exposures were demographics, comorbidities, anatomic, and operative details, and the outcomes was 30-day mortality, stroke, spinal cord ischemia, branch patency, and endo leaks. And midterm included branch patency, endo leaks, and rupture. In terms of statistical analysis, this was stratified based on arch zone repaired, and they used Kaplan-Meier curves to look at mortality, and then there was no multivariable analyses given their sample size. So in terms of results, percentage overall, 15% were zone 0, 7.5% were zone 1, and 77.5% were zone 2. And then, interestingly, there was a higher number of connective tissue disorder patients within the zone 1 category. And in terms of the demographics, you can see that this genetic aortopathy, where you can see the zone 2, or zone 1, excuse me, is where there was more frequent, although, you know, it is relative based on the sample size. Otherwise, there was no significant differences between the groups. In terms of anatomic and operative details, this was most commonly for dissection with or without aneurysmal degeneration. And these were most commonly elective in 3/4 as well. About 60% of these patients had a prior open ascending/arch repair, which facilitated a landing zone in select cases. And the procedural time was on average 159 minutes. And as you can see, as you go from zone 0 to zone 2, the time to perform these procedure dramatically decreases, which just goes to show the complexity of some of these, zone 0 and zone 1 procedures. In terms of the most common TBE size was 37, and that was followed by 40 millimeters. And in terms of the proximal cuff, there was 48% that required a proximal cuff, and this was most common in zone 1, but also quite common in zone 2 of up to 45%. And this, I think, is a testament to some of the fine tuning that hopefully gets done with the device deployment over the subsequent years. And most commonly, unilateral femoral access was utilized. And also you can see right above here, the radial was in nearly 30% of patients with 70% brachial. And there was total percutaneous in a little over 1/3 of patients, and there was 100% technical success in this cohort. So in terms of 30-day outcomes, there was a 30-day mortality of 2.5% and 5% of stroke. And you can see that this was, there was one death within the zone 0 group, and then there was one stroke within zone 1 and one stroke within zone 2. And then in terms of lengths of stay, this was, much shorter length of stay, as, Dr. Hicks had described, where you're avoiding a debranching at the time of the operation or days before. And then there was 100% side branch patency. And then in terms of endo leaks, there was a 5% endo leak, and this was limited to type 2 endo leak. And this is looking at the midterm outcomes, which extends out to type 2 as well. And the average or the median follow-up was at 202 days. And out to this time point, side branch patency remained 100%. And this is the Kaplan-Meier looking at mortality going out on these patients to 12 and 13 months. And so just really briefly, how does TBE compare to other experiences? And this was, I brought together all of the major studies that had come before, looking at zone 0 to 2 in a variety of studies. So this is the current TBE study, which had a 2.5 stroke risk and a 5% mortality. In some of the other devices out there that aren't that are approved elsewhere in the world, the relay branch, and then the Mona Lisa, and then there was this 3-vessel inner branch by Cook, and the Najuda in situ fenestration. And as you can see, that the TBE, as well as the current study looking at zone 0 and 1, all are favorable and improved from prior studies. So conclusions: repair of the aortic arch, including TBE, can be performed electively and urgently with acceptable and comparable stroke and death rates, and useful in stage repair of a type 2 thoraco. And we're still awaiting long-term safety and efficacy outside of the clinical trial. Thank you very much. I appreciate the opportunity.
Thank you. That was a very nice overview. Should I start, Misty?
Yeah, Dr. Harani, I do think Dr. Zetterval is trying to get in. If you want to see if she's in the waiting room, she just scrubbed out of a case, she said. And then.
There she is.
Okay.
Yep.
Sarah, we waited just for you.
I'm sorry I'm late.
That's okay. We can kick off the discussion. I think, if you guys have any questions or comments, you can leave them in the chat. I think I'll start off with, this is a great paper. I think seeing the TBE in the wild really is something that a lot of us have really wanted to look at for a long time, and look at other people's experiences across the country, just not in a clinical trial, but kind of outside of it too. I think a lot of zone 2 type data, theoretically a lot has been published. I think it's still very limited and usually in case series, but I think one of the things that this paper points at that I wanted to see if people had comments on is, this paper points to a lot of the use of TBE in zone 0 and zone 1. And I think this starts getting into this area of total endovascular aortic arch repair, which I think has been talked about a lot lately. My first discussion comment, and Sarah and Caitlin, feel free to chime in on this, is stroke. I mean, you guys had a very low stroke rate, and your stroke was in zone 1 and zone 2, right? And how a lot of other authors really have reported anywhere from 0 to 20% stroke rates for total endovascular arch repair, depending on the device. How would you reconcile that with your paper? Obviously, it's a small series, but what do you think that comparison? How do you think that fits in with the existing data?
I mean, I think for us, what we see is, and again, I wasn't here and I apologize for the paper discussion. I just got out of the OR, but is that most of these folks actually have surgical graft in the ascending. So you're not coming across all of that native tissue and atherosclerosis in sick patients. And so I think that's an important consideration, and probably one of the reasons the stroke rate is fairly reasonable, even though it's small. So I think that's a pretty important consideration, at least in our paper.
Dr. Abai says, in terms of cost, laser fen comes out to be much more reasonable than the use of TBE. Any comments from people who have done both? Any
I'm
takers?
happy to do it if answer that if someone else, unless someone else wants to jump
I
in.
also have an answer, but you can go first.
You're right, TBE is super expensive. There's no way around that. That being said, I think thinking of like laser, really what you're doing is burning a hole and then stretching it. And so the durability of that just hasn't been shown. I think there's absolutely a role in emergent cases where you don't have access to tools to treat patients. But I think when you have a commercially available device that's actually durable and tested, I think the kind of obligation to the clinician is to do what's kind of FDA approved, and has been shown to be safe. Because I think by definition in their studies in the animal population, which actually shows looking at laser fen that you have tears in the graft. So while that's not been published yet, I think in humans, I think it's a real problem that needs to be considered.
Babak, I think that
you know,
we do both, and I think that the way that in general we try to put TBE in people that can get TBE at all costs, because I think that, like Sarah was saying, the profile is much more known, I guess, because it's gone through rigorous trial. I will say that the times that we do use laser fen comes when you have access issues or can't fit a TBE up there because the device is huge. I mean, the profile really is big. And in a lot of people, especially women or people with smaller access vessels, diseased access vessels, it can be a really big problem. So that's typically where we make our decision, not specifically because of cost.
I would say with folks with access issue, the other consideration is transposition or bypass, and TVAR is still a great option. And I think it's important to not forget about open surgery, because I think we still have that, and that's even cheaper as well. So we use that as well for folks who are too large. I also downsize my TBEs pretty routinely.
There was a question, so many cuffs used in zone 2, any of those being arch debranching patients, and were the cuffs used to get more proximal coverage, or were they unplanned proximal extensions?
All the cuffs were planned. Again, I think you see we have a lot of open arches, and so we want to get maximal seal. And so typically our cardiac surgeons will leave us like 2 to 3 centimeters. And so I don't want to take just what's with the TBE, so we extend it to get maximum seal up there. And I know there's a lot of discussion about, the finickiness of these cuffs, but I think if you're careful and thoughtful with your wire use, they can be deployed pretty easily. And we have not had any issues with them jumping forward and covering the left carotid.
I think in the clinical trial, about 30% of people ended up using unplanned cuffs, if I remember the data properly. And I would say in our experience, we use a decent number of unplanned cuffs, but it's for exactly the reason that Sarah says. We're obviously want as maximum proximal seal as you can. And if the problem is if you land the TBE device too far forward, you're going to end up with like a 45-degree angle of that subclavian branch. And I think sort of the key to patency for that is really trying to maintain it at a 90-degree angle, and then just going with a cuff if you need more proximal seal, not trying to get that with the main device. And I think if you can sort of wrap your head around that and accept that that's okay, and then once you sort of get comfortable with deploying the cuffs, it's just like deploying those old C-tags. It's like pulling a lawnmower. You just have to have your wire sort of really pushed on the outside curve of the aortic arch. It ends up being fine, but you just sort of have to really get your mind around that mentality, so you're not cheating up on the TBE to sort of try to avoid the cuff.
I think that's a really good point. That brings me to one other thing I wanted to discuss before we move on, is that the TBE really isn't as flexible as the conformable C-tag. And we've had some issues where it doesn't really go over, especially if you have a very sharp curve. And in those instances, I've really gone towards doing a transposition and putting in a regular C-tag. And I was wondering if any of you guys had that issue as well in this.
I think I've been able to land in every patient I've kind of planned to. That being said, I think if you have to be thoughtful, as Caitlin mentioned, about like where you're landing so that you're landing in a straight section so that the, topmost area is not bird beaked around. So you can, I think the subclavian offers a lot of flexibility to cheat a little bit forward or a little bit backwards. And then with the addition of the cuff, I think you can overcome it in most patients. Certainly not all, but in most.
I will say, it's almost, these technologies, they take so long to get through the regulatory process that when they come to market, they're using old technology at that point. So they're on the old CTEG platform, and the new CTEG platform is so much better. We have like a lot of conformability. And so we see a lot of bird beaking and some difficulties taking curves. And I think just sort of being aware of that. I will say that the bird beaking tends to relax. We will just accept it. And usually on the follow-up scans, it's sort of settled out.
Yeah, I think that's where we've ended up using the most unplanned proximal extensions, is if it just doesn't quite sit right because it doesn't quite take the curve, but it's fine. You just want a little bit more extra stability there. So I think one more question and we can move on. But Sarah, and Caitlin, where do you guys see this in terms of real world practical applicability? Where do you think TBE is going to sit kind of on the spectrum of things? I mean, is everyone going to use it? Is cost going to prevent a lot of people from using it? Where's it going to sit? Total arch reconstruction only for zone 2?
I think I can answer. I think total arch reconstruction is absolutely coming. There's a clear need for it, especially in these folks who had type A's and have hemiarches or have interpositions, and they're frail and they're old and they have bad hearts. And so the cardiac folks just don't think the morbidity of an open redo zone 2 is there. So I think there's absolutely a role for it. I think we have to be careful to not overuse it, because I think in skilled hands, the open arch can be done with very good results. And so I think it's important that that does not go away. I think there's a role for both, and it's all going to be about careful selection.
Yeah, I'm all about appropriateness, right? So I feel like the total endo arches, at least currently, we don't have technically commercially available devices for that. So they really should be reserved for sick patients. So then there becomes a question around how much longevity do we need, right? We need a couple of years probably. The lifespan of these patients that we're treating is probably not that long. I think this is an exciting device. It's the first one we've seen to market that sort of provides this option. We're going to see a lot more coming to market in the next few years here, I think. And I think it's just sort of the start of a very exciting time for vascular. But I do think it's sort of important for us to remember that open surgery is not dead. There are really good TVAR devices and sort of some cervical debranching options that we have. And so it's really about sort of patient-centered decision-making and picking the best solution for the patient, as opposed to saying, I want to use this device in everybody. You have to get away from that.
Yeah, I agree. I mean, I hope there are more exciting technologies coming soon. You never know. They promise a lot, but sometimes they don't deliver. So Dr. Shames has a question. If so many people need cuffs, and if they're doing zone 0 or zone 1, do you think there is a durability issue? He doesn't think the overlap is great and suspect that might be a mechanism for failure.
So I think he's right. I think we need longer cuffs. I think as ARISE comes to trial, I think at least, I think when you have those shorter stent grafts that can kind of adjust in there, I think once you have more devices that are actually made, especially for that zone 0 patient, I think technology is going to be improving and getting better to allow us to do it better. But I think you're right. The overlap is short. And that's designed intentionally because most patients don't have long distances between zone 1 and zone 2. And so often I think the thought was that that's a limiting factor, but I think especially as you're dealing with folks who have other surgical grafts in, we need more distance. And so I think new devices are coming that are going to allow us to treat it, but it's definitely something to be thoughtful about and a drawback of what we have available currently.
For those of you who didn't know, the ARISE is Gore's trial for their ascending aorta stent graft that's supposed to dock with the zone 0, the big TBE. That's in trial now. It just started.
Thank you,
Right.
Dr. Liang, for leading us, and Dr. Zettervall and Dr. Hicks for a great conversation, and all of our all the people that put in questions. We're going to transition now from aortic work to femoral endarterectomy. And Dr. Johnson, do you want to get us started?
Yeah. So speaking about open surgery, we're going to come back to it. It's a privilege to be here. And then Dr. Serena is really going to get into the meat of this. And I'm just going to remind us of some of the key principles and things that matter for the common femoral. So I thought this was a fitting JVS paper just to bring home that endarterectomy is still the standard of care and has great patency rates. And up until, I will say recently or in the near future, we really don't have good data to support an endovascular approach at the common femoral. This is not a isolated femoral endarterectomy, but I think it demonstrates well some of the benefits of this open approach. So with a extensive disease, either moving proximal or distal, and the profunda, an endarterectomy allows you to do a profundoplasty, which really is the lifeline for the future of that leg. Not only removing disease at the origin, but also creating a wider profunda lumen. And then not all groin incisions are created equal. Not all groins are created equal either. But just as a reminder, it's often talked about as a longitudinal incision that's extensile so that you can move proximal and distal based upon disease. And a nice demonstration here of the profunda coming off. Other people talk about a transverse incision. And as you can imagine, based on my extra line here, that there are limitations in the views that can, and the extent of disease that you can treat with a transverse incision. And then some people describe an oblique incision, which in my experience ends up being maybe a longer incision with potentially more dissection, and you are interacting maybe a little bit more with lymphatics and nerves. And then the real question after this paper, I think, is there other exciting devices that might be coming on the market that can offer some comparative patency for endarterectomy in the right patient who otherwise would be too sick. So we'll talk, Dr. Serena will talk about the complications that were found in this retrospective paper, but just to keep it in mind that some people do treat the common femoral in an endovascular fashion, and some people are doing that more now with lithotripsy.
Hi, everyone. I'm Thomas Serena. I am the almost second-year fellow at the University of Utah, presenting the paper Morbidity and Mortality of Common Femoral Endarterectomy. So common femoral endarterectomy is a very standard vascular procedure, but it's often performed on very frail patients that have extensive comorbidities. The objective of this study was to revisit and study the morbidity and mortality experienced as a result of common femoral endarterectomy in a modern cohort. The study assessed all common femoral endarterectomies at a single center over a 7-year period of time. 129 patients were included in this study, and the procedures were performed by 3 surgeons. Exclusion criteria included performing CFE with infrainguinal endovascular open revascularization or an outflow procedure. Longitudinal incision was utilized for all cases, and postoperative care was standardized to skip guidelines. Most patients received standard dressings, but a subset of 11 patients did receive negative pressure wound dressings. Outcomes examined, they included all-cause 6-month mortality, and 30-day morbidity, including local complications such as hematomas, lymphatic leaks, pseudoaneurysms, wound infections, dehiscence, and systemic complications as well. Univariate screening was performed with a P of 0.1 for screening, followed by a multivariate analysis to identify independent predictors of morbidity and mortality. And again, data was collected from 129 isolated CFEs. The indications for the procedures included claudication in 36% of patients, rest pain in 16%, tissue loss in 29%, and acute on chronic limb ischemia in 21%. The mean age of the patients was 75 plus or minus 9 years, and 68% of the patients in the study were male. In regards to comorbidities, 54% of patients had coronary artery disease, 41% had diabetes, 25% COPD, and 22% congestive heart failure. 95% of the procedures were performed under general anesthesia, and patch angioplasty was performed using either bovine pericardium in 73% or Dacron in 27%. 22 patients, or 17%, sustained local complications following the procedure. Wound infection occurred in 11% of patients, dehiscence in 5%, and hematoma in 5%. In these patients, there was a significant association with obesity and negative pressure wound therapy. On multivariate analysis, this was confirmed where wounds dressed without negative pressure dressings were less likely to develop local complications. However, I'm not sure that we can say correlation equals causation, as I know that I would use this in more select patients that are higher risk for these problems. 19 patients sustained systemic complications, most commonly being sepsis, followed by cardiopulmonary complications or thromboembolic events. Occurrence of systemic complications was significantly associated with CLTI as an indication for the procedure and higher ASA at the time of surgery. 6 patients died within 1 month of their surgery, 5 of 6, which presented with acute on chronic limb ischemia. By 6 months following the procedure, 17 patients had died. In those 17 patients, there was some association with being on dialysis, presenting with chronic limb-threatening ischemia, and a higher ASA classification at the time of surgery. As expected, a high ASA class at the time of surgery was independently predictive of mortality. Flow-limiting stenosis, or occlusion of the common femoral artery, is a sign of advanced endovascular or advanced vascular disease. Patients with severe common femoral artery involvement most commonly have lesions in other vascular beds. For this reason, it's important to note that these patients are not standard risk patients undergoing standard procedures. They have a higher risk of morbidity. In addition, when looking at groin incisions, the groin has a higher bioburden than any other incisions, in addition to a location with higher tissue tension and extensive lymphatic network, which all contribute to difficulties and problems with wound healing. When looking at the literature, there's about a 10% local complication rate following femoral endarterectomy, with some studies citing this over 20%. The most common complications are wound infection and dehiscence, followed by lymphatic leaks. These complications are associated with factors which contribute to poor wound healing, such as advanced age, obesity, diabetes, preoperative steroid dependence, and reoperative interventions. Additionally, the utilization of postoperative drains has also been cited as a correlating factor. The 17% incidence of local complications found in the author series is on par with historical numbers. In regards to mortality, the historic rate of death associated with the procedure is 3%. In this study, 13% of patients had, and that's all-cause mortality, had died at 6 months. This is something that's important to counsel these patients, that this is not a benign procedure that they're undergoing, and it is a significant stress on their body. In terms of critiques and questions, this is a single center retrospective studies. The authors did an excellent job at outlining and reviewing their experience with this procedure. It should be noted that in the study group, they only received a longitudinal incision. Sometimes people will say that this is often linked to more wound healing problems or complications. One interesting detail about the paper is that 36% of patients who underwent common femoral endarterectomy underwent the procedure for claudication. I would love to dive more into this subgroup. Were these all lifestyle limiting claudication? Were they a lower ASA class? Did they have the same complication rates as other patients? And I'd also like to look at the author's definition of wound infection and hematomas and how they were managed, whether it was takebacks, antibiotics, or their management. So in conclusion, common femoral endarterectomy is not a benign vascular procedure. Disease presentation, anesthetic risk, and expected longevity play a very important role in final outcomes and decision-making. Endovascular interventions are difficult to perform in this location. However, one day, hopefully, there's going to be a less invasive way that we can help these patients. Thank you.
Well, that's a great job, Dr. Serena and Dr. Johnson. Thank you so much for that summary there. I wanted to kind of kick off. Let me just see if there's anything in the chat here before I kind of kick it off. Not yet. So please feel free to drop some stuff in the chat. As Dr. Johnson mentioned in her intro, this is such a durable operation. It's probably one of the most durable things that we do as vascular surgeons. But the one Achilles heel is kind of the wound complications. So just throwing this out to anyone on this call, and then specifically to the authors, do you think there's a role for any prophylactic groin flaps? Does anyone do that in some of these high risk patients, based on redo groin, obesity, steroid use, smoking status? Do the authors do that in their practice at all, or anyone else on the call?
That's a great question. I mean, that's something that I don't necessarily routinely use unless it's a redo groin, which, because it's a durable operation is not always the case, or is rarely. I think it's definitely something to consider in high-risk patients, such as patients with obesity, patients with, CLTI, and just a no diseased outflow, so we're not likely to require further open approach to their common femoral artery.
Yeah, and then go ahead.
Sorry, Kevin, I was just going to chime in. They didn't talk about low BMI, but that would be a patient often when they don't have enough tissue coverage. I might do a prophylactic sartorius flap, and low BMI is really associated with frailty. And so that might give you a subset of patients that are dual high risk.
Great. Here's a question from the chat. Was there any difference in outcomes comparing patch choice, so bovine versus Dacron? And did you notice any higher risk of infection or wound complications with the choice for your patch angioplasty?
No, that's something that we were particularly interested in looking at, just because of different practice patterns within that group, and we did not see any difference in local complications other than ones driven by the systemic factors rather than local factors.
Great. Here's another question, which hopefully maybe spawns some good conversation about endo options for common femoral disease. So in the past, we've treated certain patients with CFA stent with Supera, and patients that are high risk for endarterectomy or very frail. Just wondering if anyone has experience with that. So I'll piggyback off that and say, is anyone on the call doing much endo interventions for CFA? And if you are, what are you doing? Just straight angioplasty, drug therapy, atherectomy, stenting?
I think you'll find that throughout the country, there are people that are doing it intermittently. And we talk about those specific patients at various times where they happen to have any one of these characteristics. And you'll see people doing lithotripsy, and you'll see people, again, as Dr. Drudy mentioned, using stents. I think the hard thing is as vascular surgeons, most of the time we see this as a fairly benign surgery. Just as Dr. Abai said, you can do it under local, you can do it under spinal, and Prevena can prevent closures or prevent complications. And that always sounds great until you have one of those complications. And then you think, should this have been the person that I maybe tried endo on? And I think that's something that, even though we see it as almost an egregious thing to do endo in that area, I do think that there are certain cases where it's warranted, and it does help patients get through their disease state without actually having the complications that we so regularly see with these.
Yeah,
and I think that's...
Oh, sorry.
No, go ahead. Yeah.
To Humphrey's point, that was really the impetus for that paper. And actually we had a subtitle that said, not just a benign groin operation, that eventually, got off the manuscript. But But and the impetus was that, it seems like a pretty benign and durable procedure. And the other reason why we did that study was that oftentimes the outcomes are reported at, 30 days, 90 days, but rarely 6 months. And what is actually the survival of these patients that undergo a seemingly benign operation but are pretty frail. So that was the other reason to that study.
Great. Another question. Can you talk about the length of stay and discharge location, home, SNF, rehab, in this cohort of patients? Did you guys look at that at all?
I think we may have reported it, but we didn't specifically, look at independence, or I guess discharge to home as an outcome measure, which would be another thing of interest for sure.
Yeah. And one other follow-up question I had, just back to kind of the wound complications, there's in this study 17% kind of local complication rate. Did any of those patients kind of have the most dreaded complication we worry about, like a patch infection? Did you have anyone that need to go back to the OR and have the patch ripped, or someone you had to salvage with a flap? Did anyone require any kind of major surgical reinterventions?
I honestly can't remember off the top of my head. Maybe Mike Cheney, our junior author can, but there were a few that did require return to the operating room, either for a washout, a flap, or
Okay.
Yeah.
Okay.
For patch infection specifically, no, but I know there were a few hematoma evacuations and then a lymphocyte ligation.
Perfect. Here's another question. Was the higher rate of wound complications in the negative pressure group reflective of a selection bias? In other words, did the authors preferentially use a wound vac dressing in high-risk groins?
Yeah. That was our hypothesis after looking at these data. That's also something that was kind of introduced kind of in the latter part of the study. So I think there was a selection bias both in terms of patient population. So.
What is your standard kind of perioperative antibiotic management?
24 hours of skin floor coverage.
Yeah.
I want to add on to that. Are you, you're using, most of these patients had bovine pericardium. Are you using just like a cephalosporin? Are you using vancomycin? In our institution, even if you are putting in something that may be a biologic or a xenograft, it's still recommended that we use vancomycin because we have such a high level of MRSA in our facility.
Yeah, same at Duke. Yeah.
Yeah, I think unless they're patient-specific risk factors, and the majority of them get screened with MRSA pre-surgery, we use cefazolin.
Maybe changing topics a little bit. The one thing I was kind of interested in was, a third of the patients had tissue loss and had isolated femoral endarterectomies. So you can talk about, were those kind of like planned, staged interventions, or what was kind of the workflow? And it's open to anyone, or someone has femoral disease and then concomitant, infrainguinal or maybe proximal disease, or do you guys usually try to stage those or do them all in one sitting? Or
No, that's a great question, and actually kind of spun off into a different project where we looked at what we call the natural history of a common femoral endarterectomy, particularly in CL patients, stratifying by breast pain versus tissue loss and the type of tissue loss. And did find that in patients that had a pretty minor wound, particularly like the W component of the score, they fared pretty well with endarterectomy alone without the need for subsequent endovascular procedures. And those that didn't, are likely to require, even if they're frail, infrainguinal revascularization from the get-go.
Cool.
And I don't know
Thanks.
what your experience has been with that, but
yeah. And then there's one more question, or more of a comment, open to anyone here. With such a significant rate of complications, I wonder if a cost-benefit analysis of endarterectomy versus endovascular therapy would be warranted. Yeah, I don't do a lot of femoral endos. I'm not sure what the cost is. I don't know if anyone here has a sense on cost difference. I would assume, well, actually, I don't want to make an assumption. It's hard to know because I guess endo is ambulatory. So,
Well, you know, I asked Andrew Bradbury several times. I've asked him about the cost analysis of the Basel trial, and his response to me is that devices are actually a very small proportion of the costs that are associated with the treatment, and a lot of the cost is associated with being in the hospital. So if you think about these patients, if they're admitted to the hospital for 2, depending on their age, 3 days, versus being able to come in and the cost of using a device. And I'm extrapolating some data here, but I know I've asked him 7 ways to Sunday if he thought that if they used atherectomy or some of these more expensive devices in Basel, if it would not be as cost effective. And he said absolutely not, simply because of the cost of being in the hospital.
great. Any other questions or comments? It's really great paper.
I think we've gotten so much good discussion here, and thank you, Dr. Sutherland, for leading that discussion, and then of course Dr. El-Khoury for being here to give us the perspective of the authors, because there's always something underlying that we really want to get to. So we'll wrap it up for tonight, and I want to thank everybody for being here for the July version of the JVS Online Journal Club. And we can join us again in August. And we'll see you all then. Okay. Thanks, everybody. Have a good night.
Thanks.
Thank you.